New year, new you, or at least new scrubs, because let's be honest, personal growth is hard, but a great uniform, that we can do. If you work in healthcare, now is the perfect time to upgrade your scrubs with Figs. They're lightweight, durable, super functional, and so soft. Because we all know what you wear sets the tone for your entire day, and that's exactly why I love Figs. Figs makes scrubs for modern medicine. Back in nursing school, I was given these boxy, scratchy scrubs that felt like wearing a stiff paper bag. Figs completely changed everything. They're well-fitting without being restrictive, insanely comfortable, and actually made for people who work in healthcare. They're antimicrobial to help keep you protected, durable enough to survive wash after wash, and look so good you actually want to wear them. With new limited edition colors and styles, Figs is truly putting the fresh in uniform refresh. Scrubs, outerwear, footwear, accessories, you'll look sharp, feel good, and be ready to take on whatever your shift throws your way. 2026 is here, so let's do this. Take 15% off your first order at wearfigs.com with the code FIGSRX. That's wearfigs.com, code FIGSRX.
When Johann Rall received the letter on Christmas Day 1776, he put it away to read later. Maybe he thought it was a season's greeting and wanted to save it for the fireside. But what it actually was a warning, delivered to the Hessian colonel, letting him know that General George Washington was crossing the Delaware and would soon attack his forces. The next day, when Rall lost the Battle of Trenton and died from 2 colonial Boxing Day musket balls, the letter was found, unopened, in his vest pocket. As someone with 15,000 unread emails in his inbox, I feel like there's a lesson there. Oh well, this is The Constant, a history of getting things wrong. I'm Mark Chrysler. Every episode, we look at the bad ideas, mistakes, and accidents that misshaped our world. Find us at constantpodcast.com or wherever you get your podcasts.
Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast where I teach concepts and share tips to help you thrive in school and at the bedside. Thank you so much for joining me here on the podcast. Today, we're talking about something I have been wanting to go over for ages and ages. I have no idea why I waited so long. I guess there's just a million things that I've been excited to talk about, but finally we're here. We're going to be talking today about the LaTTE osteotomy, or the LaTTE procedure, LaTTE surgery, whatever you want to call it. It is an intense and very interesting surgery with a unique recovery pathway. So let's dive in. So the LaTTE osteotomy or LaTTE procedure is utilized to correct mid-face abnormalities, including things like maxillary asymmetry, malocclusion, protrusion, maybe significant underbite, and facial fractures. So you might hear something referred to as a LaTTE fracture. This can occur in trauma, like say the patient's riding a motorcycle without a helmet and they run into a cement wall and fracture their face. They could have LaTTE fractures there. In general, though, unless you're working in a trauma center, you're going to be seeing or hearing about LaTTE in the context of the LaTTE osteotomy or that surgical procedure. It's also sometimes utilized to enlarge the upper airway to treat obstructive sleep apnea in some patients, and it could even be used to improve surgical access to tumors at the base of the skull so that the surgeon can then get into that tumor and remove it. So there are 3 types of LaTTE osteotomy. They're classified as 1, 2, and 3. So the LaTTE one is the most common type of LaTTE osteotomy, and it is primarily used to improve the bite and the shape of the face. It involves a horizontal cut above the teeth to essentially separate the upper jaw from the rest of the skull. So yeah, it's intense. The jaw is then repositioned and secured into place. Now, the LaTTE 2 is where we get a little bit more in depth. The nose and upper jaw are moved together. And then in the LaForte 3, this procedure involves moving the entire midface, even parts of the eye sockets forward. This procedure is utilized to correct significant facial deformities and facial trauma. You could also have a situation where there's a combined LaForte 1, 2, and 3 to treat severe midface underdevelopment or hypoplasia. This very complex surgery combines all levels of the LaForte osteotomy to divide the midface into multiple segments, which are repositioned independently. So again, it is a pretty intense procedure. I've seen some surgical photos that were honestly kind of hard to look at, but maybe I'm just a wimp. If surgery is the sort of thing that interests you, this would definitely be one to check out because I do find it really fascinating from a nursing standpoint, and it's also pretty interesting from that surgical side as well. So we're going to be talking through the LaForte osteotomy using the straight A nursing latte method, basically looking at it from the standpoint of your patient underwent a LaForte 1, which is the most common type again, and now you're basically taking care of them afterwards. I will say that commonly patients undergoing a LaForte procedure, at least in the facility where I work, would spend one night, their first night post-op, in the ICU, and that is because we need to really keep a very close eye on them and their airway. And why will become very clear as we go through the LaForte osteotomy using the straight A nursing latte method. So, you ready to dive in? Let's do it. So, we'll start out with the letter L, which stands for look. How does the patient look? Basically, what are their signs and symptoms? So, prior to surgery, the signs and symptoms the patient has really depend on their particular abnormality. They could have pain with chewing. They could have an inability to align their teeth or difficulty breathing through their nose. It could really be all kinds of different things depending on what's going on with their facial structure. But after surgery, you're going to see that in most cases that jaw is wired closed. There could be some other kind of closure device, like a internal fixation device, but most of the time you're going to see the jaw wired closed, swelling of the mid and lower face, because obviously the face has now been through a lot of trauma. Oozing of blood is pretty common, and you'll also see some kind of device used to support the jaw and offer compression. Now, this could be a head and chin wrap that anchors at the top of the head and provides upward support beneath the jaw. That's what I would usually see. But some patients, depending on which surgeon they had, would come out with a device that basically wraps around the head in the same way, but also provides continuous cold therapy. So it's providing compression, support, and continuous cold therapy. And those patients were, I would say, much, much more comfortable. So in general, that's what you're going to see in your patient after they have had a LaForte procedure. Next is A for assessments. How do we assess our patient after they've had this procedure? So anytime you're caring for a patient after surgery involving the nose, the oral cavity, the neck, anything in that area, you want to be very, very hyper aware of their airway and keeping a very close eye for any signs of airway compromise. This can include inability to clear secretions. It could be stridor that you would hear. It could be even loud snoring when they're asleep. So always watching for any signs of airway compromise. Some other very important key assessments are to keep an eye on their oxygen saturation level. Hypoxia can occur due to airway occlusion, airway compromise, and hypoventilation associated with anesthetic agents and opioids. I remember as a pretty new-ish nurse taking care of a patient who had just come out of a LaForte osteotomy procedure and was in a ton of pain, got some opioids, not that much. He must have been very opioid naive and just became so drowsy and then kept dropping his O2 sats. I do believe we had to give Did we have to give Narcan? I can't remember, but we were very concerned about his airway and his ability to ventilate. And, you've got a couple options here. When the jaw is wired shut, you can reverse the opioid to wake the patient up, or you can cut the wires and open the jaw and do bag valve mask ventilation. Surgeon really, really, really did not want the wires cut. So I don't remember if we gave the Narcan. You know what? As I'm talking about it, I do remember I went to go grab it as one of my coworkers stayed at the bedside. And by the time I got back, the patient was more awake and more rousable, and the little situation had passed. Maybe it was just the whiff of Narcan in the air. I don't know, just kidding. But luckily, I do remember that turned out just fine. But we were very, very, very concerned about any kind of issue with the respiratory system. So, watching their SpO2, watching the respiratory status, their pain level. The procedure can be quite painful, especially when more complex or higher level Leforts are performed. So, you're wanting to keep a close eye on that patient's pain level. It is, I have seen or noticed, a bit less when the patient does have that cold therapy device. So, just keeping an eye on that. In addition, if the patient complains of a headache, not necessarily pain in the jaw or the face, but a headache, that could be a sign of a CSF leak, which is rare but can occur with the Lefort procedure. While we're talking about pain, let's talk about sedation level. You want to keep a close eye on this as well, like I just said with my little story, being very careful with your opioid administration and hyper vigilant about watching the patient's ability to stay awake enough to protect their airway, ventilate adequately, all of that, keep their SpO2 up. We're also looking at swallowing ability. So, damage to facial nerves can occur during this procedure. So, if your patient is drooling excessively, that could mean some kind of obstruction situation going on. It could mean they're having trouble swallowing. So, this could be a sign that you would want to look more deeply into their swallowing ability before starting them on their diet. With that said, frequent swallowing may be related to excessive bleeding from that surgical site. So, if the patient's swallowing constantly, you want to be getting in there and seeing if they're bleeding a lot. The patient could also have nausea. So, after surgery, if they've swallowed blood, especially, which is pretty common, that can upset the stomach, make them nauseous. Anesthetic gases can make them nauseous. Opioids can make them nauseous. So, lots of high risk for nausea here. We definitely want to keep a close eye on it because remember, the jaw is immobilized in these patients. And if they start throwing up, they are at high risk for aspiration. Now, we talked a little bit about facial nerves being damaged. Let's go ahead and do just full-on cranial nerve assessment. Remember, cranial nerves can be damaged with facial trauma, and basically a Lefort procedure is facial trauma, even if it's conducted for reasons such as an underbite. The patient's having facial trauma from the surgery. Other patients have facial fractures from an accident of some kind and then would have a Lefort procedure to correct that. So always be thinking about facial trauma and cranial nerve assessment. I did locate a study that was conducted in 2018 that showed the main nerve affected is the trigeminal nerve, and they were looking specifically at Lefort 1 procedures. So it was the trigeminal nerve, followed by oculomotor, abducens, optic, then facial, vagus, and accessory nerves. So quite a few nerves can be affected. So you might as well go ahead and do that cranial nerve assessment on your patient. Something else to be watching for and assessing is for bleeding. You're looking for any signs of bleeding just as you would with any surgical patient. There are some arteries up in there that could be affected. So hemorrhage is a definite concern and a potential complication. So keeping an eye on that. And CSF leak, it can occur after a Lefort osteotomy. Remember, CSF is a colorless fluid. So if you see it leaking from the nasal cavity, which is most likely where it would occur, but if the patient has had extensive facial trauma, it could leak from the ear as well. So if you see that colorless fluid, you should be testing that to determine if it is CSF and letting the physician know that you're seeing this clear fluid. So, a quick bedside test that can be conducted is the halo sign. This is not a definitive test, it would still need to be sent out for further testing. But the halo sign is basically done by taking a drop of that fluid, and there's likely going to be blood mixed in there with that CSF. So you drop that fluid onto a piece of gauze, and the blood will stay in the center, but the clear fluid will spread around it, forming a halo. And that is considered to be a sign that that is CSF fluid. So we'll talk a little bit more about the tests as we get into the next section of the LATTE method. So that is the second T. It is for tests. So one is that CSF testing. So let's say you do the halo test or whatever, you're really thinking that this is CSF fluid. Maybe the patient has a headache along with it. CSF leak would cause a headache. For definitive results, samples of that suspected CSF fluid can be sent to the lab for a beta 2 transferrin test. So you've got a CSF leak, you want definitive answers, advocate for a beta 2 transferrin test. There's also imaging studies done, especially preoperatively. That could be x-rays, CT scans of the facial bones, all of that sort of thing. There may be x-rays and whatnot done afterwards to see how things are looking, especially if there is some kind of a complication that is occurring. Mostly, though, you'll see the imaging studies done ahead of time. A CBC can tell us about potential blood loss and if the patient is growing an infection with a elevated white blood cell count, which is what you would see on the CBC. And then coagulation studies could be really important in any patient with a bleeding disorder, a coagulopathy, who is having excessive bleeding, or who had significant facial trauma. Let's take a quick little break, and then when we come back, we'll talk about treatments and the massive amounts of patient education. The holiday decorations are coming down. There's no longer an endless supply of cookies and chocolate in my kitchen. It's basically that time of year when I like to treat myself to a little something special, or maybe a few little somethings special, which is where Quince comes in. Because Quince partners directly with manufacturers, they're able to pass their savings on to you. So you can get luxurious clothing and accessories at prices that are 50 to 80% less than similar brands. Now, I've got my eye on a couple of things that I think will go a long way toward brightening my winter mood. One is a dolman sleeve cashmere sweater that's priced at just under $40. And the other is a lightweight puffer jacket that's just $79.90 that I plan to take with me for some hiking in Sedona in a few weeks. Treat yourself this winter without the luxury price tag. Go to quince.com/nursemo for 365-day returns plus free shipping on your order. That's QUINCE.com/nursemo to get free shipping and 365-day returns. Quince.com/nursemo.
When it's time to scale your business, it's time for Shopify. Get everything you need to grow the way you want, like all the way. Stack more sales with the best converting checkout on the planet. Track your cha-chings from every channel, right in one spot. And turn real-time reporting into big-time opportunities. Take your business to a whole new level. Switch to Shopify. Start your free trial today.
So far, we've talked about how the patient looks or their signs and symptoms, the key assessments, and some tests that could be conducted for a patient undergoing a LaForte osteotomy. Now let's talk about treatments, which is the next letter in the LATTE method. So something you'll be doing as the bedside nurse after this procedure, you're watching for all of those complications, and you're also doing a fair amount of bedside interventions. One of those is suctioning. Frequent suctioning can help keep the airway clear And it can really help you keep an eye on how much bleeding is occurring. Now, I have learned from experience that when the patient's mouth is very, very tender, they can't open very far, they've got those wires in place, it's really difficult and painful to stick a stiff Yankauer into the oral cavity. And it's a little bit much. So, a nurse hack that I was taught by my veteran nurses at the bedside was to take the more flexible, thinner tubing that is used to suction tracheostomies and attach that to the suction setup and use that instead. So it's much gentler, it's flexible, it's not all hard and pokey, and it can fit all around the mouth, even with the wires in place to get at those areas where there is blood pooling. You want to be very, very careful that you're not dislodging any blood clots as you're suctioning. You want to be very careful you're not disrupting any sutures, anything like that. So, very gentle, but probably frequent suctioning. Positioning is also an important nursing intervention. Maintaining the patient in an upright position is going to do two very important things. It's going to reduce swelling and it's going to reduce the risk of aspiration. Looking at pain management, a lot of your interventions are going to be focused here. So, using multimodal pain management strategies, that's the compression of that head to chin wrap. That's that upright position to reduce swelling, which reduces pain. That's using ice or the cold therapy device that some patients will have. It's utilizing opioids in combination with things like acetaminophen and NSAIDs to manage pain so that you're using the least amount of opioids as possible because you really don't want to compromise respiratory function. So, multimodal pain management. You're also managing nausea. Since vomiting with an immobilized jaw can be an emergent situation that can lead to airway occlusion and aspiration, then nausea should be treated pretty aggressively and proactively so that we avoid it altogether, ideally. So, medications that are used to treat nausea or prevent nausea include ondansetron or Zofran, metoclopramide, also known as Reglan, scopolamine. It's possible they could have a scopolamine patch. It's an anticholinergic that can reduce nausea. Dexamethasone, which is a corticosteroid that can reduce nausea, and promethazine. These are all medications that can be utilized to have an antiemetic effect. And what I have found with patients with post-op nausea or nausea from having surgery and then having opioids and all of that is that a multimodal approach is really, really helpful. A lot of times, just giving Zofran alone isn't quite enough. Many times it's, a combination of things. So keeping in mind that if one thing doesn't work, it's not game over for you. Go and see what's next. A lot of times, antiemetic orders will be in a stepwise fashion. First, give this. If that doesn't work, then give this. If that doesn't work, then give this. So checking to see what you have. And if you don't have anything else, what are you doing? You're making a phone call and you're asking for more medication. Now, if the patient does vomit and is not clearing their airway, you have any concerns about airway compromise, those wires must be cut immediately. Now, cutting the wires, definitely something we want to avoid doing. If at all possible, it would be an extreme situation where we would cut the wires, but that is basic wire safety, that if there's airway compromise, even questionable here, your hospital protocol, your surgeon orders will most likely state to cut the wires. And for this reason, wire cutters should be at the bedside at all times. The patient should come out from surgery with those wire cutters at the bedside. Another treatment is fluid replacement or maintaining good fluid volume status. Now, if the patient's NPO prior to surgery, then they're probably likely a little bit dry. It's going to be difficult for them in the very initial post-op period to be taking in fluids initially. So IV fluid replacement may be necessary in that immediate post-op period. After the patient is able to swallow safely, then we want to progress to taking in oral fluids. Supplemental oxygen may be needed to keep that SpO2 above the MD's ordered parameters, usually above 92%. And then, of course, nutrition. The patient's going to start out on a clear liquid diet and then advance to a full liquid diet by time of discharge. So, the difference between clear liquids and full liquids is that your clear liquids are basically anything that is a you can see through, I guess, anything that is clear. Doesn't mean just water. It could be broths. So the broth in the hospital, the chicken broth, the beef broth, the vegetable broth, what have you, that's considered a clear liquid. Juices would also fall into this category. But at the time when they're having that clear liquid diet, it is going to be pretty limited. So hopefully they're doing well and can advance to at least full liquids, which would be more like anything that is in liquid form. It does not necessarily have to be see through or have clarity to the liquid. So, for example, a creamed soup would be a full liquid as long as it doesn't have chunks of food in it, right? Like a totally pureed soup, like a butternut squash soup. That sounds lovely. That would be considered full liquid. A smoothie blended really well would be considered full liquid, etc. So they're going to be on a clear liquid diet initially and then advance to full liquid by time of discharge. Oral hygiene is also really important. So we're going to be keeping the oral cavity clean with oral hygiene products that won't cause irritation or damage to that surgical site or the sutures. So in the clinical setting, we have those spongy swabs. Those could be utilized with a disinfectant mouthwash to keep the oral cavity nice and clean. We're not going to use the hospital toothbrush. It's not soft enough, so those swabs are going to be great. And then communication. Since it's going to be difficult for the patient to speak, remember, their jaw is wired closed. So we need to provide alternate forms of communication, such as a whiteboard or a notepad or some kind of phone app. So, as you can see, there's quite a few things that you will be doing as the bedside nurse as you're taking care of these patients. Highest priority item, keeping that airway clear. All right, the final bit is education. What are we going to be teaching our patient? So these patients will have their jaws wired or wear elastics for several weeks, like 4 to 6 weeks after surgery. So there's quite a bit of education that should be provided to them. And ideally, this education is starting early on. So you're not just piling all this on the hour before they're discharged. So always be teaching to discharge topics as you are working with your patients. So, some general education includes that blood clots in the sinuses are really common after that Lefort 1 osteotomy, and they do clear out on their own. It can take a while, it can take a few weeks. So, it's really important the patient avoid blowing their nose for probably at least 2 weeks, maybe longer, depending on what the surgeon advises. They can use saline nasal spray to keep the nose clear, keep the membranes moist, and help those blood clots just kind of work their way out. So, blood clots are common and don't blow your nose. If they do have to sneeze, teach them to sneeze with the mouth open as much as they can to help keep the excess pressure from building up in the nasal cavity. And speaking of pressure, they should not be flying. They should not be scuba diving until cleared by their physician. And they should also not go swimming because high risk for infection there. They should avoid strenuous activities and definitely contact sports until cleared by their surgeon. This is usually going to be at least 4 to 6 weeks. We don't want any trauma to the face or the jaw happening during that very critical healing time. The sutures that are placed are going to dissolve on their own and then they fall out. So they dissolve internally and then the little pieces that are sticking out just fall out. And this takes about 4 to 5 weeks. Now, they will be getting several different types of medication, pain medication, probably some antibiotics, maybe Colace or something like that, a stool softener. So if swallowing pills is going to be difficult for them after they're home, then we really should be talking to the physician about writing discharge medications that are in liquid form so that they can get easy to swallow items from the pharmacy. You also want to make sure your patient knows to avoid smoking for 4 to 6 weeks. Smoking really, really, really impairs healing. So a nicotine patch could be something that you would advocate for a patient who is a smoker and seems like they're going to be having a hard time abstaining from that. Let's be kind to them and get them a nicotine patch. As far as diet goes, you want to make sure the patient understands to maintain the diet prescribed by their physician for that period of time prescribed by their physician. And that's going to be liquid or pureed diet for probably up to about 6 weeks. And speaking of their diet, they really should be mindful of their calories because it can be really easy to lose weight when you're only taking in liquid or pureed foods. So they need to be mindful that they're getting enough calories. They should also avoid using a straw, as this can dislodge blood clots. It can disrupt the stitches, it can damage the surgical site, and delay healing. So instead, initially, they might want to use like a feeding syringe initially in those first couple of days, and then progress to sipping things from a cup as soon as they are able. Definitely no straws. For oral hygiene, they're going to be rinsing with whatever physician approved mouthwash. They might write them a prescription for something, and to do that as directed, probably 2 to 3 times a day. As far as brushing their teeth goes, they can use a soft toothbrush in most cases. An infant toothbrush is really great for this. It's got very, very, very soft bristles. They should avoid brushing the incision lines at the gums, mostly just focusing on the teeth. Now, some patients will have elastics in place, and maybe the physician will say you can take the elastics out to brush, just put them back on afterwards. Others will say don't touch the elastics. And in other cases, the jaw remains wired. So it's going to depend on the patient and their ability to be flexible to really get to all areas of their teeth. Basically, you're teaching the patient, do the best you can with the limitations that are in place. And then pain control. Teach the patient to sleep with their head elevated. Again, that's going to reduce swelling. And if they don't have a cold therapy device that's running continuously, they can use ice packs for 20 minutes at a time. They should also take their prescribed pain medication as ordered. In general, the pain's most significant in the first couple of days, maybe 2 to 3 days after surgery. After that, they generally should be able to manage pain with acetaminophen and NSAIDs. You also want to let them know that numbness in the lower and upper lips can be pretty common after this procedure because of the nerves being affected. And it can take quite a while for that to resolve. It can take months, like 6 months, 12 months for that to resolve. Let them know that feelings of like electric shock or pins and needles is a sign that the nerves are recovering so that they're not, alarmed by that. Teaching about nausea is that it can occur after surgery because the blood that was swallowed, opioid pain medications can cause nausea, and we really don't want them to be vomiting. So antiemetics hopefully have been prescribed as needed. Sipping clear soda like 7 Up or ginger ale can really help. And this is also just another opportunity to teach them the importance of sticking to that liquid diet so that if they do throw up, it's going to flow out through the wires or the elastics or whatever is immobilizing the jaw. Tell them if they do throw up, if it gets to that point, they should assume an upright head forward position so that they can help prevent aspiration. And they would want to let their MD know just in case maybe additional antiemetics are needed. And of course, if there's any suspicion of aspiration. Now, speaking of that, when else would you want to teach the patient to call the MD? Well, with any surgery, signs of infection, maybe there's a foul smelling odor coming from the surgical site or some foul smelling drainage. If there's unrelieved pain or worsening pain, that can be signs of infection. Warmth, redness anywhere near that site could be a sign. And then, of course, an elevated temperature. Pain that worsens or is unrelieved by medication would warrant a phone call to the surgeon. Again, suspected aspiration. You'd want to call the surgeon because this can lead to aspiration pneumonia, which is very, very serious. If the patient's excessively sleepy, if they're, especially the first day or so after surgery, excessively sleepy, especially With opioid use, we want to make sure the physician knows that might be an emergency type situation. Any concerning neurological symptoms would warrant notification to the MD, such as vision changes or difficulty swallowing or difficulty speaking beyond what is expected, because it is difficult to speak right after the surgery. They've changed the whole shape of the person's face. And any continuous clear drainage from the nose, possibly the ears, most likely the nose, would indicate a CSF leak. So making sure the patient understands that's not normal. Call your doctor, especially if you have a headache along with that. I will say that of all the patients I've cared for who've undergone Le Fort procedures, the transformation in their physical appearance is really, really dramatic. And in most cases, it is an improved appearance because any abnormalities have been corrected, any asymmetry has been corrected, but it is a really huge change for the individual. So you may need to be doing some therapeutic communication with your patient as they adjust to this new image of themselves. So there you have it, your quick guide to caring for a patient after a Le Fort osteotomy. I do have other episodes about surgical procedures or surgical items of interest. A couple that I think you might really enjoy checking out are episode 100, which is caring for a patient after a thyroidectomy. Again, neck surgery, airway issues. And then another one is episode 302 on a post-op complication that's rare but terrifying and dangerous, which is malignant hyperthermia. So again, those were episodes 100 and 302. Make sure you come back and join me on Monday following this episode for a little pod quiz on this topic. See you soon. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.